Hello, today we are going to explain about the cytologic features of HSIL mimics or pitfalls in gynecologic cytopathology. Before we dive to the further of HSIL mimics and pitfalls, let us revise a few characteristics of high-grade squamous intraepithelial cells HSILs. So it started with high NC ratio with 3 times or more nuclear enlargement, coarse chromatin, hyperchromatid, thickened and irregular nuclear membrane with scanty cytoplasm. It also has spatial characteristics, which is groove, and the arrangements can be divided by two, the syncytial tissue fragments, and also the discrete and singly scattered cells. After we have known the true characteristic of true HSILs, let us move to the HSIL pitfalls. So what is exactly mean by HSIL pitfalls? HSIL pitfalls are misleading features that can mimic or mask the HSILs, causing overdiagnosis or misdiagnosis. As you can refer to the table, false positive usually happens when it is not a HSIL, but we report it as HSIL. So this is usually due to the mimic, which is gonna look like a HSIL, but it's actually not a HSIL. So this will lead to the overdiagnosis. Next is false negative, which usually happen when it is a true HSIL, but the cytologic features can mask it, hiding the true HSILs. So this is usually due to the mask, which we're going to hide the true HSILs, and it will lead to the misdiagnosis. And there are two major aspects of true HSILs that can be mimicked by other cytologic features, which are the first one, discrete and singly scattered cells, which can be mimicked by the immature squamous metaplasia and also atrophy. And next one is tissue fragments, which can be mimicked by the immature squamous metaplasia, eyes of endocervical, and also adenocarcinoma. These two major aspects will be further viewed in this video.
Next, I'll be talking about atrophic cervicitis, a common in postmenopause women due to estrogen level that decrease significantly, and thus it will lead to the thinning of the cervical and vaginal epithelium. One of the problems with atrophic changes is that they can mimic a serious condition, especially HSIL. This similarity can cause overdiagnosis, where the patients may be suspected of having precancerous. At the same time, due to fewer exfoliated cells that can be seen in smear, there is a risk of false negative. Apart from that, other diagnostic difficulties include drying artifacts, inflammations, and low cellularity that can affect all the nuclear details and smear quality. Now, let's look at the microscopic features of cytology of atrophy. The smear typically shows parabasal cell, small, round to oval, uniform, high NC ratio, and pyknotic nuclei. These cells form tissue fragments that show folding at the edge, and if we are not careful, they might be mistaken for a syncytial group seen in HSIL, which is a cluster of cells with no clear border, where the nuclei are crowded and overlap. Next is the presence of orangophilic cytoplasm due to degenerations. This cell might look like dyskeratotic, which is referred to the squamous cell that undergone premature or abnormal keratinizations. Next, similarity between background cells in atrophy, lack of nuclear characteristic of HSIL cells. The singly scattered cells around tissue fragment are often pleomorphic in shape, but when carefully examined, nuclei are either smudged or too hyperchromatic.
Now, let's talk about the blue blobs. Blue blobs is a classic feature of atrophic smear, especially in postmenopausal women. Blue blobs appear as a small, round to oval structures, smudged and densely cyanophilic color with ill-defined borders. Blue blobs used to be thought of as mucus, but studies have shown that they are actually degenerated parabasal cells. This can be confirmed by a positive result for cytokeratin and EMA, which are a marker for confirming that blue blobs is epithelial cell origin. Electron microscopy even shows tonofilament confirming these blobs are collapsed cell skeletons. Blue blobs are caused by lack of estrogen and degeneration due to dryness and poor mucus flow. Now, let's recap the common mimics in atrophy. So in atrophy, the tissue fragments of parabasal cell may mimic syncytial fragments, which will resemble HSIL. The high NC ratio and sometimes hyperchromatic nuclei also resemble the HSIL characteristic. Pseudochondrocytosis may sometimes present, which may be confused with low SIL. Now, let's focus on the differentiation between atrophy and HSIL. So to summarize, this slide will help us to differentiate between atrophy from HSIL by comparing the key cytologic features. So first of all is the cell uniformity. Atrophy show uniform parabasis cell, while HSIL cells are variable. Next is NC ratio. Both may appear high, but in atrophy, it's consistent across the cell. The chromatin for atrophy has evenly distributed and sometimes smudged chromatin, while HSIL shows a coarse and irregular chromatin. For nuclear membrane, atrophy has a smooth nuclear membrane, meanwhile HSIL have irregular and thickened nuclear membrane. For syncytial fragments, atrophy has a folded tissue fragment which may mimic the syncytial, while HSIL have a true syncytial fragment. For the cytoplasm, atrophy has degenerated atrophic cell which may have orangophilic cytoplasm, unlike the abnormal keratinized cytoplasm of HSIL. And lastly, the pseudochondrocytosis can also occur in atrophy, leading to potential confusion with low SIL. This shows the microscopy differentiation between atrophy and HSIL. At the right side can be seen that the atrophy microscopy shown a uniform parabasis cell, high NC ratio, and smooth and evenly distributed chromatin, while at the left side, the HSIL microscopy shown a high NC ratio with nuclear enlargement, coarse, irregular, and dense chromatin.
Next HSIL mimics is immature squamous metaplasia ISM. It is a defense mechanism in which the columnar cells lining the endocervical surface and glands are replaced by immature squamous cells. It happens due to chronic irritation of the cervix. Characteristics of ISM is monolayered, smooth nuclear membrane, fine and evenly distributed chromatin, nucleoli present, and dense cytoplasmic differentiation. Next is the differences between HSIL and ISM. HSIL has very coarse chromatin, whereas for ISM, it has fine and evenly distributed chromatin. HSIL has thick and irregular nuclear membrane, meanwhile ISM has smooth and regular nuclear membrane. There is no nucleoli in HSIL, but nucleoli is present in ISM. HSIL has scanty cytoplasm, but ISM has normal cytoplasm. NC ratio in HSIL is very high, whereas for ISM, it is slightly high.
Next, I will be explaining why transitional metaplasia or TM can be misinterpreted as HSIL during cytologic evaluation. Firstly, transitional metaplasia is a benign and non-neoplastic epithelial change. It occurs when the endocervical columnar epithelium transforms into transitional type epithelium, which resembles urodelium, the lining seen in the urinary tract. Under the microscope, TM will appear as a hyperchromatic cardiac group or HCG. These are tightly packed cell clusters that appear dark or hyperchromatic. TM is composed of small cells with three main features, which are nuclear groove, hypochromatic nuclei, and high NC ratio. Let's compare transitional metaplasia and HSIL side by side to understand how to differentiate them in cytology. First, in terms of cell arrangement, TM show monolayer sheet with a trimming or railing pattern, and the cells are often ovoid to spindle shape. HSIL, on the other hand, appear as a disordered and crowded cluster with round or irregular cell shape. For chromatin, TM has fine and evenly distributed chromatin, meanwhile HSIL show very coarse chromatin. The nuclear membrane is TM is usually inconspicuous or smooth, whereas in HSIL, it becomes thick and irregular. Regarding nucleoli, TM may have presence but inconspicuous nucleoli, meanwhile for the HSIL, typically has absent nucleoli. And lastly, the cytoplasm, TM cells have a scanty cytoplasm, meanwhile in HSIL, the cytoplasm is very scanty. Now let's compare the microscopic appearance of transitional metaplasia versus HSIL using real cytologic images. Left side is a transitional metaplasia that have a scanty cytoplasm, fine and evenly distributed chromatin, inconspicuous nuclear membrane, and also have a nucleoli present. Meanwhile, for the right side is a HSIL that has a very coarse chromatin.
Next pitfall of HSIL that I'll be discussing about is tubermetaplasia. Tubermetaplasia is a metaplastic changes of glandular cell, specifically endocervical cell. It is also known as benign alteration of endocervical cell, where the non-ciliated columnar epithelial cell is replaced by ciliated columnar cell that is similar to the cell found in the fallopian tube. Here are some similarities between HSIL and tubometaplasia that might get us confused. So both possess high NC ratio with nucleus enlargement, cross chromatin, presence of nucleoli, vacuolated cytoplasm in some cases for tubometaplasia, and hyperchromaty. With all the similarities, how do we actually differentiate between HSIL and tubometaplasia? Here are some key features for us to look out for. The first one is the background, where HSIL possess dirty background appearance compared to clean background of tubometaplasia. Other features such as mitotic figure, terminal plate, and cilia are only present in tubometaplasia and none in HSIL. Additional immunocytochemical staining, P16Ki67 stain, are essential to differentiate precancerous and non-cancerous cell, where HSIL stain will appear positive and tubometaplasia results are negative. Here are some pictures to better demonstrate between HSIL and tubometaplasia. Tubometaplasia background is clean, while HSIL will appear dirty, and the presence of terminal plate and cilia are only present in tubometaplasia. Mitotic figure present in tubometaplasia. And addition immunocytochemical staining of HSIL and tubometaplasia. That is all from me. Thank you.
Next is a HSIL with glandular involvement. HSIL with glandular involvement is a variant of HSIL where the spastic squamous cell extend into the endocervical glands. This type of lesions is important because it often mimics glandular lesions such as adenocarcinoma in situ, AICE, or atypical glandular cell AGC, making diagnosis challenging.
Now, I will be presenting one of major pitfalls in cytology, misinterpreting HSIL with glandular involvement as glandular lesion with AGC or AICE. Let's start with the common pitfall. First, this plastic squamous cell may be few or hidden among benign endocervical or atypical glandular cell, making them easy to miss. Second, squamous sheet can appear glandular at the edge, especially if they form rounded cluster which lead to misdiagnosis as AGC. Another important point is the presence of the chromocenter in squamous cell. This can be mistaken as nucleoli, a feature typically seen in glandular cell. Lastly, over-reliance on architecture like cell arrangement without assessing nuclear features such as chromatin pattern or nuclear shape can lead to incorrect interpretation. So, to avoid all this mistake, we must actively look for isolated dysplastic squamous cell and closely examine nucleus feature. Next, this table shows comparison between HSIL with glandular involvement and true glandular lesion. Architecture for HSIL tend to form syncytial cluster with swirling, while glandular lesions show more organized honeycomb pattern. Nucleoli usually absent in HSIL but often present in glandular cell. Nuclear growths are often seen in HSIL where they are usually absent in glandular cell. Cytoplasmic process and cross-chromatin also favor HSIL, where glandular lesions tend to have fine chromatin and vacuolated cytoplasm. Lastly, diagnosing AGC triggers further procedures like colposcopy and endometrial sampling, especially for women over 45 years old. However, many AGC diagnosed are actually squamous intraepithelial lesion on histology, about 50%. Only 1% are AICE and 0.5% adenocarcinoma. So always consider HSIL with glandular involvement in your differential and combine nuclear detail with architectural clues for the most accurate diagnosis. Accurate classification is essential to avoid unnecessary procedures or mistreatment.
So, in conclusion, to differentiate HSIL with its pitfalls, we can focus on the key and the differential features that define the abnormal epithelial cells, which are nuclear enlargement, nuclear characteristic like chromatin and its nuclear membrane, the amount of cytoplasm and its arrangement, together with the overall view under 10. That's all from us. Thank you for watching and don't forget to like our video. Thank you.